I'm just thinking...
EPRR?
No, I think we carry on. Thank you. Right, okay. Let me turn to item 10, and we've got delegation of primary medical services functions. Ian?
So the purpose of this item is to seek formal agreement from the board to the delegation of the function of primary medical services commissioning to 51 CCGs as a second kind of wave. This is within the context of extant NHS England policy to support applications from CCGs to take on these functions as part of the joining up of NHS commissioning functions to provide a better focus on place and better integration of services. Secondly, within the context of the robust management of conflicts of interest, including our new strength and guidance, which we've just discussed. Thirdly, and I've touched on this already, a formal assurance process overseen by Commissioning Operations Directorate and our regions. And then fourthly, what I would describe as an initial broadly positive set of information of the likely benefits from co-commissioning, including through a survey of CCGs that have gone for either delegated or joint arrangements, discussions with NHS England's regional teams who've been involved in the functions hitherto, and many continue to, and some emerging examples of CCGs, but it's still relatively early days to be able to make a full assessment. We are nonetheless keen to get independent and clear feedback on the efficacy of the new arrangements, including through a formal independent evaluation which is being undertaken by the Policy Research Unit for commissioning, and we will have, as I say, further data in due course. On the basis of those that brief explanation, I invite the board to approve the delegations.
This is an extension of what we're already doing. We have some understanding of how that's working in practice. We know we'll have more in due course, and on that basis, may I invite the board to approve the proposals in the paper. Good, thank you very much. I'd like to move now on to item 11, which is the Emergency Preparedness, Resilience and Response paper, and to invite Bruce to speak to it.
Thank you very much, Chairman. Under the Civil Contingencies Act 2004 and the Health and Social Care Act, we have responsibility, this board, for taking over the effective functioning of the NHS in the face of significant disruption. And the aim of this paper is to assure the board that we are assuming that responsibility effectively, but not to induce any sense of complacency. I won't run through the paper itself, but I would like to make a few remarks about some additional issues. The first is that about a month ago, we were part of an exercise called Unified Response, which was one of the biggest exercises ever undertaken in Europe to simulate a major disaster with over 1,000 casualties. There were teams from 3 other countries. It had been over 18 months in the planning, and the end result of that was that the health component of that stood up very well with no major deficiencies exposed. The second issue that I'd like to raise, which is in the particular context of clinical experience, is that we have had 2 learning events to try and understand what happened in the Paris attacks and what could have been done better. The most recent of those was the 8th of March in Birmingham, and major trauma centres, the military and other people with interest took part. We're currently awaiting a call with the French Health Ministry to exchange our learning with them. But I think it would be fair to say that we have a good understanding of that, and that we believe that our major hospital incident plan is equivalent to their white plan, and it is as effective, and that our mass casualty plan is the equivalent to the French red plan and is just as effective. The third thing I'd like to say is that during the course of the year, we had to deal with the Ebola epidemic emerging in West Africa. And I think it would be remiss of me not to say that our first lesson that we learned from that, and I'd like to say this on behalf of the Chief Nursing Officer, myself as Medical Director, was an example of remarkable selfless professionalism from many people working in the NHS who demonstrably put their own health at risk for the sake of others. And I think we owe them a debt of gratitude. And I believe that we acquitted ourselves pretty well in the Ebola epidemic. The risk that ensues from that is that somehow or other some complacency does emerge, and that all our protocols, our structures that we put in place, and the learnings just somehow or other get stuck on a shelf and they gather dust. So to ensure that that doesn't happen, that we maximize the relationships that were built throughout the United Kingdom, not just England, for tackling Ebola are kind of cast into the DNA of the way we do business with highly infectious communicable diseases. We've asked Mike Jacobs, who was the lead clinician for the Ebola epidemic, who works at the Royal Free Hospital, to help us distill those learnings and to embed them. The fourth area that I'd like to pass comment on is that pandemic flu remains on the National Risk Register as a very significant and potential problem, and that the Department of Health will be conducting a major exercise to try and understand how we would deal with that in October this year. The fifth and sixth issues are related, and they refer to the junior doctors' strike. So next week, between 0800 on Wednesday and 0800 on Friday, junior doctors will be undertaking another of their strike actions. Emergency services will be covered. We have undertaken, or in the process of undertaking, a data collection to understand how each trust will deal with this and to assure ourselves that we're in a reasonable place. That data collection closes at 5 o'clock this evening, but early indications are that we don't expect there to be any difference with this 48-hour disruption to the previous 48-hour. But there is one small caveat to that, and that is that the strike next week will coincide with the changeover of about a fifth of junior doctors in the country between different organisations. And so we've had to work closely with Health Education England to ensure that we have the right induction processes in place to ensure that those junior doctors who are changing institutions, and particularly those who might be on call the following weekend, are properly inducted. And the consequence of that is that most trusts will be running 2 induction processes, one on Wednesday and one on Friday, to ensure that that's covered. The next issue is the subsequent strike in the last week of April, which I think will elevate the potential disruption to the NHS, both in terms of safety and maintenance of service, in a way that we haven't seen so far, because during working hours, junior doctors will be withdrawing cover for emergency services. Now, we propose to undertake data collection and initiate our assurance process immediately after next week's strike, in order that we can have a deeper understanding of exactly what the implications are for that, so that we will have that analysis complete a week in advance of the strike. We would then propose to share that with the British Medical Association in order to put in place the agreed protocols that we have with them and the mitigations to ensure that the risk to both the NHS and our patients is minimised. Thank you.
May I invite comments and queries too? No, well, I think, Bruce, thank you for that very thorough report, and we watch each of those developments with great concern. But can we also endorse what you said about the Ebola response, which I thought exemplifies some of the very best practices of medics and other clinicians and other staff right across the NHS? Right, we turn now to committee reports. We have, first of all, the commissioning committee. David?
Nothing to add to the report, Malcolm.
Thank you very much. Investment committee, Moira? David again, audit and risk.
Nothing to add to the report, Malcolm.
Right. That brings me to any other business on which I have 2 items, if nobody else does. The first is just to record that the board yesterday made some awards to celebrate outstanding performance by several of our staff who'd been identified by their line managers. And they were people who had gone the extra mile, and I was very happy to host, along with Simon and the other members of the board, a ceremony and also a luncheon to celebrate what our key staff do for us. The second is to record again, as I did at the outset of the meeting, that this is Margaret's last meeting as a board member of NHS England, and to invite the board in a moment to express their appreciation for all that she's done. Margaret joined us in 2012 as one of the pioneers on what was called the NHS Commissioning Board. She was then company secretary and legal counsel to John Lewis Partnership, and brought many of those values of retail and wrapping the package, as it were, around the client, around the patient, that has helped to steer us over the past 4 years in our thinking about the way in which we should organise our activities through NHS England. And also, Margaret, consistently around issues of governance and propriety of behaviour, for which we're immensely grateful to you. So may I, on behalf of all the board, wish you well now in your new role as chair of ActionAid, and thank you on the behalf of all of us for the enormous contribution you've made to our thinking and to our proceedings over the past 4 years. Thank you very much. So I now invite the board to pass the usual resolutions. We move into private business, and I declare this meeting closed. Thank you very much.